one of the projects that I've been working on with Dan Abrams, who was the guy who came up with this idea in the first place. The idea basically is to administer drugs that we use to treat psychiatric illnesses. Right now, most of these drugs, we give them orally for the most part. Occasionally, some of them are administered as injection. But these drugs, you're treating the entire body with these drugs when you give them peripherally. And where we need them is here, because they're for psychiatric disorders or other CNS problems. Now, a lot of these drugs have really, really bad peripheral side effects. Some of them are lethal or can be potentially lethal in certain patients. It would be really nice if we could put them where they're needed. There's a lot of advantages to that. It doesn't get out into the periphery, or it gets out in minimal amounts. We can get away with much, much smaller doses. So this was the concept that we initially started with, and the first drug that we began looking at is Clozapine for schizophrenia. And this is a proof of concept study. Schizophrenia is really a devastating, devastating disorder. It affects between 1% and 2% of the population worldwide. It really disrupts the patient's life, and it disrupts the significant others of the patient. And right now, the drugs that we've got to treat schizophrenia generally are not terribly effective. Part of the reason being that schizophrenia is a spectrum disorder. It has a vast range of symptoms that are associated with it. And the different drugs, different ones that we have, target different groups of symptoms. There's nothing out there that works really well for everything, and a lot of them do have peripheral side effect issues. So if we could stick these drugs directly where it needs to be, into the brain, we could have significant advantages. We could avoid these peripheral side effects. We could dramatically drop the doses that we need to give the patient. So we started out with Clozapine as the first drug. And Clozapine was proven about 3 or 4 years ago in a head-to-head study sponsored by NIMH against all the other schizophrenia drugs out there to be the superior drug, hands down. It is the best thing that we can give, and it's about the only thing that will do any good in patients who are refractory to the other drugs. They simply don't respond to the other drugs. Clozapine is the one that they will respond to. The problem is it's got a really bad side effect that shows up in, as high as 5% of the patients. It's a lethal blood disorder. And we have to monitor these patients initially every 2 weeks, then every 4 weeks, then every 6 weeks to make sure that their liver functions are going okay because of this lethal side effect that we could see. If you've got a paranoid schizophrenic, the idea that you're going in and taking their blood every couple of weeks, this does not go over well. None of you would like your blood taken every 2 weeks. A schizophrenic is really bad. So it would be really nice if we could administer this really powerful drug in a better fashion. So we can get it in there. We know we can stick it into the brain, but is it going to do what it's supposed to do? How can we test this? Well, schizophrenia, as I said, has this huge spectrum of symptoms, and a lot of them are really, really hard to measure. Things like hallucinations, that's one of the hallmarks of schizophrenia. How do you quantify hallucinations? The patient can't tell you, I'm having them an hour and 20 minutes out of every day. They don't know. Some of them, it's continuous. How severe are the hallucinations? Are they disrupting their lives? Or they're just something going on in their head? You can't quantify these things. The vast majority of schizophrenia symptoms are not quantifiable. However, back in the mid-'80s, the guys that I work with found one that is quantifiable, that is related to a lot of the other symptoms that we see in schizophrenia. So we can measure this in humans, and we have a great model in animals as well. What we're looking at is something called auditory gating. It is sensory processing. If we experience the same stimulus once and then again in a very short period of time, we processed it once already. We don't need to reprocess it. We heard a noise, we've already figured out it's not a lion over our shoulder ready to pounce on us. It doesn't mean there's a mate nearby. We know what the information is. We get that stimulus again in a short period of time. Why would we completely reprocess it? We're literally wasting brain power on it. So the brain has a way of filtering repetitive information that's coming in a very short period of time. And we found a way to measure that. We actually put an electrode right here on the scalp, and we present identical auditory sounds, and they just sound like clicks a half a second apart. So what the patient is hearing is click, click, No change in intensity, in frequency, nothing. Everything's the same. If we look at a normal individual, we're reading the EEG response to that stimulus, you get a nice big response to the first stimulus because we're processing it. What is the information that's contained in that stimulus? When it comes again in a short period of time, we don't need to reprocess that. So we don't. There's an inhibitory circuit that we recruit when that first stimulus comes through. So we don't reprocess it. On the other hand, a schizophrenic reprocesses. They are paying attention to everything. In fact, one schizophrenia patient said to my boss, Bob Friedman, everything has to have all of my attention all the time. So a schizophrenia patient in like a cocktail party atmosphere where there's a lot of stuff going on cannot pay attention to a single conversation because they're paying attention to everything. Other conversations, a schizophrenia patient in this room right now would have a problem because they'd hear the fan associated with the projector and they'd be paying attention to that. Is there something in there that I need to pay attention to? So they lack this inhibitory circuit. We actually understand the mechanism behind this now, and they actually have a reduced number of a certain kind of receptor in the brain. And because of that, they don't have this circuit. Now we call this first stimulus the conditioning stimulus. We call the second the test stimulus. That comes important in a moment. And we can actually quantify these numbers by measuring from year to year and year to year. And if we take this height and divide it by this height, we get a number. And when this response is smaller, then this response, that number is less than 1. If they're about the same size, it's going to be 1 or greater. Normal individuals have this TC ratio, that's what we call that, at about 0.4 to 0.5. Schizophrenics are up in the neighborhood of 0.1. This individual is running right at about 1. And I said we can model this. What we found was there are some strains of inbred mice which show normally without any intervention, we're not getting in there with behavioral or drugs or anything, spontaneously look like normal individuals. You can see there's a nice big response to the first stimulus and a small one to the second with a ratio of about 0.17. This strain of mouse, the DBA2 mouse, you can see the responses, actually the response to the test is a little larger in this particular mouse. So his TC ratio is 1.14. We have used this mouse extensively for drug development, for looking at mechanisms underlying the deficit that we see in the mouse and which we now know is the same deficit in human beings. So we tested this mouse by giving clozapine directly into the brain. We already knew if we gave it peripherally, it would improve auditory gating just like it does in human beings. So we gave it directly into the brain, and you can see the response to the first stimulus got bigger. The response to the second stimulus got smaller. These are the guys receiving the clozapine directly in the brain, and these are the guys who just received the vehicle for it. That is just the solution that it was dissolved in. And as you can see, the TC ratio is dramatically lower. So yes, indeed, in this mouse model, we put it directly in the brain, we get the equivalent result to what we get if we give it peripherally, but the dose is dramatically smaller than what we have to give if we give it directly into the body of the animal. Well, if we are to give a drug into the brain, boy, it can affect a lot of other things. It happens when we give it peripherally as well, but boy, going to the brain, we really need to know, is it affecting other behaviors? So in this case, we turn to rats because they're a little larger, a little easier to work with, and there's a nifty little drug delivery system that you can implant under the skin right back here and have it deliver the drug directly into the brain for up to 4 weeks. So the animals here actually have the implant. You can't see it because the animals are healed up. And we tested 3 different behaviors. One of them is called the open field maze, and all it is a great big black box. And we put the animal in there, and we track him with a computer and look to see where's it going. And what this tells us, is the animal sedated? If he's sedated, he's just going to sit in the corner and sit there. Is he activated? If he's activated, he's going to run like crazy. Is he... Does he have any anxiety? Rats basically don't have much of a way to protect themselves out in the wild. Basically, they want to escape. And they want to stay where it's safe, and they want to stay where it's dark. So usually they'll hang out in the periphery of the box. As you can see in this image, we started in here. He ran, crossed in the middle, and ran out to the edge here. Stayed, for the most part, out on the edge, a little in the middle. This test looks at whether they are activated or sedated, And if they're less anxious, they'll spend more time out in the middle of the box where it's less safe. The elevated plus maze is a better anxiety test. It literally is a plus, it's an X. And you can see 2 of the walls are enclosed and 2 of the walls are open. And it's sitting up about 2.5 feet above the floor, which is pretty high for a rat. And if they are anxious, they hang out here in the enclosed arms. If they're less anxious, they'll move out into the open arms. The third test we did is the pour salt first swim. And this is as best we can measure a measure of, quote, depression. And I put that in quotes because we can't ask a rat, do you feel depressed? Because they can't answer us. But we believe that the amount of time that they struggle or are just kind of hanging in water where they cannot escape kind of measures behavioral despair. And we know that if we give rats drugs, which we know in human beings help depression, it will reduce the amount of time they just kind of hang in the water and they struggle more. So these are the 3 tests that we used in these rats to determine if there were any behavioral changes associated with giving clozapine directly into the brain. In the open field, all that happened was they ran a little more at the highest dose. This is the amount of time they spent in the outer region of the box, so near the walls, and you can see it doesn't change, but the distance they ran goes up, which means they just ran faster. So they're ever so slightly activated. They are definitely not sedated. There is no real difference in the amount of time that they spent or the distance they traveled in the center of the box. That's a less good test for anxiety than the elevated plus. This is the elevated plus, and as we go up in dose of clozapine, you can see they spend less time in the closed arm and more time in the open arm without really, these are not statistically significant for each other, without really changing distance. So here we're not seeing an increase in activity particularly, but a little bit of anxiety reduction. So this drug directly administered to the brain is slightly anxiolytic, which is not a negative thing. It could be considered slightly positive for this drug. And the pour salt first swim across the doses did not change the amount of time they just kind of hung in the water versus the amount of time that they struggled. So it's not showing any antidepressant activity. When we looked at the histopathology, nada. We're not seeing any changes in the tissue, particularly the cells which line the ventricles of the brain, which is where we're putting this drug. So it looks really safe, and clozapine is a drug that's currently approved for human use. This is just a new way to administer it. So overall, what we found is that clozapine administered directly into the brain improves auditory gating, just like it does in human patients and like it does if we administer this drug peripherally. It doesn't cause sedation, does not seem to have any detrimental behavioral changes. So these data suggest that we actually can put this into the brains of human beings and see a positive result at a dramatically reduced dosage. The technology to put this into the brain exists right now. It's currently used for the most part to deliver drugs into the spine for people who have chronic pain or spasticity issues. It has been used into the brain in a few cases to deliver anti-cancer therapies for tumors, and there were no problems associated with the technology itself. The drug is an approved drug. So we are hoping that this will allow us to fast track, and we hope to go into human beings with this in the latter part of this year or early next year. We'll actually have a meeting with the FDA in about 2 months for a preliminary. So this work was supported by the TTO grant and the state grant, and these are the individuals who helped me with all of this. I did not do all this myself. So are there any questions? Okay, that's it.